Okay, in chapter 10, we're going to be talking about the management of discomfort of our mom while we're in labor, the different things that we can do intervening with medicine and non-medicine kinds of approaches. And then chapter 11 will be fetal assessment during labor. I've said before, and we can all appreciate that there is going to be discomfort and pain during the labor and birth process. But how people recognize it, experience it, deal with it, manage it, whatever, is going to be unique to the individual. What, from a nursing perspective, is important is for us to be able to understand where this pain is coming from, to be able to ascertain with the mother's help what's going on, how is she experiencing it, how is she feeling it, and how does she want to manage it. So first of all, we look at where does the pain stem from, what's the origin of it. The first one we're going to talk about is visceral pain, and this is pain that comes from the labor process, the changing of the cervix, the dilation, the stretching of that lower uterine segment, the uterus itself as it's contracting, not having any blood flow, so not having any oxygen to it. When the woman is experiencing this visceral pain, it can be referred to other areas, and it can be experienced and identified and felt in places like the lower back, the anterior thighs, the abdominal wall muscles. And that's why a woman can experience the low back pain, and it's actually a visceral pain in its origin. In comparison, the somatic pain is actually the body pain that is triggered from once the second stage is there and she has this intense, sharp, burning pain that comes from the stretching and the distension of the perineum, the tissues, the pelvic floor, things that actually allow the passage and the expulsion of the fetus for delivery. Again, how we perceive and express and deal with pain is going to be unique to the individual. If remember this, the acronym PAIN. Pain is purposeful. There's a reason that you're hurting. These are things you can tell your mom. It's anticipated. I'm telling you, you're going to hurt, okay? So we can deal with this pain. We can identify it and we can deal with it. The pain is not constant, it's intermittent. If it were constant, nobody would be able to do this. But because it's intermittent, we know when it's coming, we can manage it. And the end is that it's necessary because that pain is from the contractions that you're experiencing that's pushing that baby out so that you'll be able to hold it. So being able to explain what's going on a lot of times can help your patient identify with, okay, where am I in this process? How can I deal with it? Break it down into little pieces at a time. You have some cultures that are all about vocalization, that will cry out, they'll moan, they won't just hold it in. And then you've got your more stoic cultures where to utter any sound or syllable is a sign of weakness, and they're not going to do that. You may have a woman who is experiencing pain, but in deference to her partner's sensitive stomach or whatever, may not want to call out or cry out because she doesn't want to upset her support person. Cultural expression of pain varies amongst individuals and sometimes even amongst cultures. So as a nurse, it is very, very important that you are culturally aware and sensitive to what your patient needs. So it's important to identify maybe what experiences your mom has had associated with pain. Most people don't look at pain and go, oh, yay, I get to hurt today. There's usually a negative connotation associated with it. So what are the things that are associated with her pain, okay? Is there some associated physiologic factors going on? Does she have a previous back injury? Has she strained something? Is there another issue that's going on? We talked about culture. Is she a stoic individual, or does she need that vocalization, that calling out? Does just humming or chanting or anything, does that help her? If she's anxious, she's not going to do well for the simple reason that being anxious heightens her oxygen demand. She becomes more tense. She fights the pain instead of going with it, which can actually lead to a level of hypoxia, which makes the pain worse. What were her previous experiences with childbirth? If she's ever had a baby before, how did she deal with it? Did she have a bad experience? Did she use analgesics or anesthetics, or did she just try and do that with non-pharmacologic therapeutic interventions? The gate control theory of pain is very important to be able to think about. And simply put, a pain, your nerves can only handle one impulse. So if you've got a pain impulse going to the brain saying, hey, I'm hurting, but you can put something else along that same route, then you can theoretically diminish the pain impulse by giving the brain something else to process. And here's an example. Anytime, all right, ladies, say if you've been cooking and you splatter grease on yourself and it is burning like crazy, and you go and you put your arm where you've got that grease splatter under cold running water, as long as it's under the cold running water, it doesn't seem to hurt so bad. You're like, okay, I can tolerate this. But the minute you take it out from under that cold running water, the pain comes back intensely. Well, when it was under the water, it wasn't that the pain was gone, it was that your brain was processing the sensation of the cold water, and so you didn't recognize the pain from the burn so much. Guys, think about any time you've been working and you're hammering and you hammered and hit your thumb or something. You know, if I've ever done something like that, the first thing I do is pop my thumb into my mouth and suck on it, and then start shaking my hand and jumping up and down. I may even say some nice, colorful words. None of that makes the pain stop, but it gives my brain something else to process so that I don't feel the pain sensation to the same level. Gate control pain theory is applicable in labor and delivery because if we can take these prepared childbirth methods of massage, the focus guided imagery, relaxation techniques, then we can offset some of the sensations that the mom experiences when she is having the actual pain. So non-pharmacologic management for pain discomfort is something that is legit, but it is not something that just comes easy, and it's not something that you can do right off the bat. The good thing is it's relatively inexpensive. Sometimes you have to have little props like maybe a stuffed toy or a tennis ball or a rolling pin or some music, but it is generally safe. It is non-invasive. It's simple. It just takes some practice. You don't want to wait until the moment you're actually in labor and then try and do meditative breathing and relaxation and guided imagery, because you're going to be so stressed out and feeling the pain that it's not going to do any good. These are things that need to be initiated and practiced in the weeks preceding labor so that when mom gets into labor, she is able to employ these non-pharmacologic interventions and can actually deal with the pain without the use of medication. Now, there are different childbirth preparation methods you may have heard about. The Dick Reed method is sometimes referred to as childbirth without fear. A woman is taught to breathe during her contractions, with her contractions, and with pushing. And they're also taught to relax different muscle groups throughout the body, kind of intentionally, progressively, controlling, contracting, releasing the muscles to the point that they get to, in labor, being completely relaxed all over their body except in the uterus, which is actively contracting. So the uterus is still being a power, doing its work, but the rest of the body is able to breathe and relax. Lamaze is a method using the psychoprophylaxis, and that simply means Lamaze is into the guided imagery, into the relaxation techniques, using massage techniques as a way to go to that gate control pain theory we talked about, to where if I am massaging and rubbing up and down the back, effleurage, the gentle massage, circular motion on the stomach, then I can't be focused on the pain that much. The Bradley method is husband coach labor. When my baby brother was born back in 1973, I was 8 years old, but I can still remember when mom went into labor, going into the hospital and sitting in the waiting room in those fluorescent, lit rooms. People were allowed to smoke back then. My daddy smoked, and he, would just pace up and down, around in the hallways and in the rooms, because moms were put back in labor and they were kept there. And a lot of times they were drugged up, and their support person, which usually was the husband, was separated. And so they did not have that support there. What Bradley did was say, okay, we need to put these two together. They need to be each other's touchstone and support. And so Bradley introduced the husband coached method. Childbirth preparation classes really are focused on giving a woman as much information as she can take in, to give her control over her labor and her birth process. Childbirth preparation doesn't mean no pain. Childbirth preparation is a method to give you tools that will be useful to help you manage the pain that you have. There are women who, if they really seriously commit to doing this, will not use pharmacologic interventions, that they will have a completely natural childbirth process because they're able to breathe well, to relax well, to shift their focus off of the pain and onto something else. So specifically, what are we talking about with these little different interventions? Well, with relaxing and breathing techniques, something called a cleansing breath, which is a deep breath in all the way through the nose as deep as you can, and then blow it out through pursed lips completely. Doing that at the beginning of a contraction and at the end of the contraction gives the body oxygen to be able to tolerate it. Plus, it kind of breaks labor down into segments so that the woman can actually get through the labor because another little piece is behind her. The relaxation, much like the Dick Reed method of being able to consciously relax the body. Tighten up the fist and the arm and hold it and then relax it, because then you have control over something. With breathing techniques, for the contractions, it's the paced breathing depending on the intensity of the contraction and where it's falling. This is the that's going to be that early breathing, and then as the contractions intensify and get stronger, it becomes and that will be at the peak of the contraction to help her breathe through it so she can stay oxygenated but still handle that pain. Imagery and visualization is where you may have somebody, a doula, a caregiver, somebody else who is maybe reading a poem to you, or you may have a mother who just closes her eyes and listens to music. Or we actually had a situation where somebody was playing, a salt and pepper song. That was very interesting to help her get through the pushing and the birth. Guided imagery, take you on a trip. What's your happy place? My happy place is the beach. So close your eyes and imagine that you're on the beach. Do you hear the sounds? Can you smell the salt in the air? Do you hear the gulls? That is what imagery and visualization is going to be. The effleurage, again, those circular movements. Typically, they're going to be on the abdomen, just slow circular movements, but you can also do those on the anterior thigh. And counter pressure, imagine when you've got a headache, how you'll take your fingers and you press in on your temples, because when you put that pressure against your headache, it alleviates the headache a little bit. The same thing is when you're in labor. If you put counter pressure on the lower back, then that can offset some of the pressure and the pain that you're feeling from the contractions. Other interventions to think about are the acupressure and acupuncture. Now, around here, we don't have acupuncture as a therapeutic intervention. However, you can appreciate maybe some of your bigger cities or different cultures would utilize some of that. Application of heat and cold, depending on what she is experiencing at the time. She may want a warm compress, something maybe along the lower abdomen just to kind of help with that muscle cramp that she feels, or she may want something cold. Touch and massage is very ticky in the sense of there are women who don't want to be touched, and then there are some who want a firm touch. So again, these methods, you need to start practicing them before you actually get into labor. The woman needs to identify what intensity and depth of touch and or massage does she want. Does she want a light stroking, or does she want a firm pressure? Hypnosis, biofeedback, those are not things that are employed around here, but with the biofeedback, sometimes women will listen to things like in the evenings. They will recognize their own body. It's that tensing and relaxing on cue to the point that when they are experiencing the pain in labor, then they can use that to control the sensations they're feeling. Aromatherapy is a ticky kind of thing again, because depending on how the woman's progressing, as her labor advances, certain smells become very noxious to her and can cause her to be sick. So in the beginning, before it gets too intense, the aromatherapy may be okay. She may like a spearmint, she may like some lavender or some vanilla, but keep in mind that as the labor progresses, some of these things may change. So we're going to talk about the drugs now. And the first class that we're going to talk about are your sedatives. Sedatives are just for relaxation in essence and to help the woman get some sleep. If you've got a woman who's in a long, early, or latent phase of stage 1, maybe somebody who's had a long prodromal labor period, they just need to rest, okay? They need to relax and to chill out a little bit. So a sedative can help them do that. It can be an adjunct to your opioid medications in that if the woman can relax and quit fighting the pain, that may allow any administered opioid to have a better effect, and it may minimize some of the nausea that they have to go along that's associated with the narcotics. Your phenothiazine groups, such as your Phenergan or your Vistaril, they don't relieve pain, okay, but they do help decrease anxiety and apprehension. They can make them sleep a little bit. Your Phenergan it's commonly utilized with your narcotic pain medicine because depending on the narcotic, you can have a side effect of nausea and vomiting, and so the Phenergan helps offset the nausea and vomiting, and it can give you that sedative effect. What you have to be concerned about is how much of the medicine has the potential to affect the fetus and affect its ability to breathe on its own, because remember, the neonate is a respiratory driven creature. You, with your narcotics as well as certain medicines like your Phenergan, you got to be sure that what you're giving isn't something that's going to impact the neonate, and or that you give it in appropriate time space. The next level are your analgesias and your anesthesias. Now, analgesia kind of helps deal with the pain. The anesthesias completely block it out. Okay, so analgesia, you may still feel it. Anesthesia, you really shouldn't feel pain. You may experience some pressure or sensations, but it should block the pain. So when you're looking at your systemic analgesias, you've got your narcotic agonist, and then you've got your agonist antagonist. So different categories that we have to look at. Demerol meperidine is not being utilized as much anymore because the metabolite, the normeperidine, in the neonate is actually causing neonatal respiratory depression. So there are still some providers who use it, and they'll just use a low dose of it. But in general, providers are getting away from the meperidine use, and they're going to an alternative. Fentanyl and sufentanil are short-acting opioid agonist medications that are being utilized, with sufentanil being utilized more increasing because of the more potent action and effect that it has when it's used as an epidural anesthetic instead of analgesia. However, when you're dosing with fentanyl and sufentanil, you do need to do more frequent dosing with the epidural because of their relatively short duration of action. So as a result, these opioids are more commonly administered by epidural alone or in combination with a local anesthetic such as your Marcaine. And hydromorphone or Dilaudid is another potent opioid agonist that can be given either IV or IM. And if it's given IV, the onset of action is typically within 10 to 15 minutes. Peak effect is 15 to 30 minutes. IM is going to give you an onset of 15 minutes and a peak of 10 to 60 minutes. Your butorphanol or nalbuphine, your Sedal or Nubane are a category of agonist-antagonist analgesics, and you do need to use those in caution with your drug-dependent mothers. That is a very, very big point to remember, because it may precipitate withdrawal symptoms in both the mother and then the newborn. And you always have to remember your antagonist, the naloxone, the Narcan. You need to have it available for the mother, but it should be available in all deliveries because it is a component of NRP, your neonatal resuscitation. If you've given the woman a systemic opioid thinking that she had some hours before delivery, and it relaxed her to the point that she had a precipitous delivery, and you deliver that neonate when the medication is at a peak in the system, then you're going to have a respiratory depressed neonate, and you need to be able to have the Narcan for the baby. Okay, well, now we're going to talk about blocks and anesthesia. Imagine when you go to the dentist and you're going to have a tooth filled or a root canal or any kind of dental work. They do a local injection. So they take a needle and they put numbing medicine just around the nerve root for whatever tooth they're working on. You don't feel the pain when they start doing anything, but you can definitely feel when the doctor is touching you, when he's pressing against your jaw or anything like that. That's the same concept as blocks in OB. Your local perineal infiltration is just a local that is injected just around the vaginal opening and perineal area, pretty much when the baby is ready to come out. It is a local, it is just numbed for just that area, or if there's no anesthesia used at all during the delivery and the doctor has to sew something up, either in episiotomy or laceration, then they'll inject a local anesthetic. The pudendal nerve block, you can see figure 10.9 on page 301 in your textbook, is an illustration of what that is. It's actually injecting the anesthetic right along the pudendal nerve area so that it numbs that nerve so that the passageway, the birth canal, is numbed as the baby's coming down. So the woman can still feel her contraction, she can still feel, how to move. It's just she has that pain sensation numbed down so that she doesn't feel it. Your spinal anesthesias and even your epidurals that we'll talk about, they give really good blockade as far as feeling anything. Your spinal is pretty much, it paralyzes you, from the waist down, definitely. It actually goes in through the third, fourth, or fifth lumbar interspace into the subarachnoid space, is what your book says for technicalities. You have to be careful because if it's too high a spinal, you don't want it to paralyze the phrenic nerve and make your diaphragm immobile. So they'll usually be lower than that because we just want it to be able to bathe the nerves that are innervating around the uterus. A disadvantage with spinal is that it is a complete blockade, so she can't move or anything like that. There's a longer recovery time. Disadvantage, if it's a high spinal, then you can have respiratory distress and or respiratory arrest. But a big concern is the hypotension that you can get with it. And if we have a decrease in maternal blood pressure, then that's decreasing maternal perfusion. Ergo, she's not going to put blood to the uterus to go through the placenta to get to the baby. She is going to save herself, and she's going to shunt blood to her brain, her heart, and her adrenal glands. So it's a cascading kind of effect. If you get the hypotension with either a spinal or an epidural, you're going to have a drop in blood pressure, which is a drop in circulating perfusion, which impairs your placental perfusion to the fetus, and you run the risk of ineffective breathing patterns. The second thing to worry about is a headache. When they've got these anesthetic agents injected into the subarachnoid space, you could theoretically leak cerebrospinal fluid. So a treatment for that is an autologous blood patch. You may have just heard the term blood patch. Once they inject that their own blood in, it seals over that hole and it keeps the CSF from leaking out, so it helps stop the headache. Now, if you look on page 302 in your book, you will see in Figure A the actual levels of injection for a spinal versus an epidural block. And then if you look all the way down at the bottom, you can see the level of saturation, for lack of a better word, that you have to get with the anesthetic for a vaginal birth as compared to a cesarean birth. So you can see spinals, which are used more appropriately in cesarean deliveries, you have to have that higher anesthesia effect because of the cutting and then the actual pushing on the abdomen that you have to do with a cesarean delivery, whereas with a vaginal delivery, it's going to start lower down, pretty much at the level of the mons. With the epidural anesthetic, these are better for vaginal deliveries because the woman should still be able to feel something as compared to a spinal where she feels nothing. If she can still feel contractions, then she can more effectively push with the contraction and bear down in second stage so that she can deliver the baby more effectively. So a good anesthesiologist is one who will give what we call a lighter epidural. So it may be a little heavy during the labor progress itself when we're going through stage 1, but by the time we hit stage 2, hopefully that has worn down enough to where, yes, she's still going to feel some pressure. She may even feel some discomfort with it, but she should be able to use that to her benefit to be able to push a little bit more effectively. One of the bad things, I guess, that you could say about the epidural, aside from the hypotension, is just the fact that it's not a guarantee. Just because you get an epidural does not guarantee complete analgesia and numbing for you. By that, I mean you can have something called a hot spot, which means that, maybe from the groin down, everywhere is numb except your right hip, or your right side may be numb, but your entire left side is not. It all depends on how the medication is injected and how it bathes around the nerves as to how much analgesia, anesthesia effect that you get from it. So an epidural isn't an absolute guarantee that it's going to work effectively all over the place, but it is a good alternative to be able to let the mother not feel the pain, but be able to feel the pressure and use that pressure sensation to her advantage with pushing. As with anything, you're going to have your contraindications to being able to use it. Now, obviously, anticipated hemorrhage is going to be a reason not to. Remember how we talked about the headaches, the leaking of the CSF? Well, we don't want there to be anything where we can potentiate a bleed. Not to mention, you are injecting, you're piercing the skin and through the tissue. So if we have a bleeding risk, we don't want to give it yet another avenue to bleed out. Any coagulopathy, which kind of goes hand in hand with the maternal hemorrhage concern. You never pierce through an infected site. I mean, think about IVs or just drawing blood or anything. You never put a needle through an infected site because that's just potentiating and exacerbating the infection. And then if there were any increased intracranial pressure, well, we don't want to have CSF that's under pressure, and then as soon as you create an outlet, it's going to come whooshing out. So all of those things would be contradictions to being able to utilize an epidural. Now, obviously, if a mom straight up refuses, that's a no-brainer. You're not going to do it. And then there are different types of maternal cardiac conditions that you can look at in your book that could be a reason to not do it. As far as side effects, you should be able to say the number one concerning side effect with epidural or spinal anesthesia is hypotension. Remember, there is a physiologic vasodilation effect from the medication. If you have that vasodilation, you're going to have subsequent hypotension. If you have hypotension, you're going to have diminished uteroplacental perfusion. Therefore, your fetus is going to get hypoxic because there's no blood going to the uterus. So there's no oxygen coming from the blood from the uterus to the placenta to the baby. Other things that you could worry about, again, the headaches, fever, itching is a very big side effect that goes along with epidurals. That is one of the more common things. You may have a longer second stage if mom has such a heavy epidural that she doesn't feel the contractions well enough to have effective pushing. If you look at box 10.4 in your book on page 305, you can see the full list of side effects. Another positive aspect of nerve blocks is that they have little to no effect on the neonate. So you should not have to worry about a respiratorily compromised neonate struggling to breathe if you use blockade analgesias and anesthesias. Nitrous oxide is something that's not utilized a lot around here, but it's actually making a little bit of a resurgence in general for women to use when they are in labor. This is something that is self-administered. Nitrous oxide is laughing gas, just to be clear, kind of what the dentist gives you to relax you a little bit. I can remember when I was 16, I had to have a tooth pulled, and I was paranoid of needles like no other, and so he gave me some laughing gas to kind of chill me out before he went to numb me up. And to this day I can't remember the numbing, but mama said that I was just a laughing and a giggling, and all the way out into the lobby in the waiting room of the dentist office she could hear me carrying on. So it works very well to relax you and kind of calm you down. The way a woman in labor uses it is she'll have a face mask. When she knows the contraction's about to start, she'll go ahead and she'll put the mask on, and she'll just breathe slow and steady in and out, breathing that nitrous oxide in. And then when the contraction is easing off and stopping, she will remove the mask and she'll just breathe regular air. So the nitrous oxide kind of helps combat the pain without having a systemic opioid medication on board. The nurse does need to be careful to watch for dizziness, hazy memory, drowsiness, vomiting, such as that as your side effects. General anesthesia is rare, and I say rare, I don't know if I've ever seen it used for a vaginal birth. It's not even used for elective cesareans anymore. About the only time I have seen them sleep a patient is when it's a true urgent emergent cesarean delivery situation, and they've got to hurry up, they've got to get that baby out. They'll put mom to sleep, and within 60 seconds they'll have a baby out, because when they put her to sleep with general medicines, then you do have that risk for it to go to the baby. You know, you say, how can they get a baby out in 60 seconds? Well, it is really, they put her to sleep and they're immediately cutting. And instead of the nice, precise, let's cut through, you know, tease our way through the layers and everything, they are just cutting all the way down. And there have been reports of, you know, babies being cut. You may have a cut on the face or on a limb or something like that. But when you stop and think about it, would you rather have a baby that is dead or compromised from having those medications circulating in, or would you rather have a baby that's live and vigorous that has a cut that's going to heal? So when you look at it that way, you kind of see the bigger picture. But you do need to make sure that you have resuscitative equipment around, because you may need to do some resuscitation with your baby depending on what the situations are and what medications have gone in. Caring for your patient in labor, it just takes a lot of different things. Now, we talked about non-pharmacologic interventions, therapeutic interventions that you can do, massage, guided imagery, things such as that. But as much as anything else, you just need to be supportive, to be her touchstone, to be a guide, to be a cheerleader sometimes, to tell her that she's doing well, and to not judge. If you've got somebody who's come in and says they're going to go natural childbirth all the way, and then they hit about a 7 and they're screaming and they're like, I can't take this anymore, just give me the drugs, give me an epidural, then your job is to give her the drugs and give her the epidural, okay? You need to support her in whatever she needs and do it non-judgmentally. Tell her how great she's doing, and there is nothing right or wrong about the choices that she makes. As long as she holds to, those are her choices, okay? With pharmacologic interventions, anything that's a procedure needs to have informed consent, which means if you are going in and the epidural, the blocks, or anything, any intervention has to have informed consent. Most admissions in labor and delivery have a blanket consent form that says anything that we feel needs to be done to you, we can do to you, okay? Timing of administration for things is very, very important. If you're giving an opioid analgesic, you don't want to give it if she's got less than an hour before you expect her to have the baby. Because if you do, you're going to have a respiratorily depressed neonate. If you are doing an epidural, what's the right time for that? Well, there is no rhyme or reason. A good rule of thumb is typically when they're about 5 centimeters, then you're going to be able to administer it and it shouldn't slow things down. But I have worked with doctors that says as soon as they cross the threshold and they say, I want my epidural, you go ahead and let them have it. I've had women who have labored all the way up to 9 centimeters, done fine, and then said, I got to have it. And instead of encouraging her to just go on, you know, we can do this, then the doctors will say, okay, you can have your epidural. The only, I guess, concern for me with that is if you're getting the epidural, it's not just, okay, I want it, and immediately it's going to be administered. There's prep work that has to go into it. Remember, we're concerned about hypotension as one of the biggest primary side effects with the epidural. So we preload them with at least 2 liters of fluid, theoretically increasing their circulating volume so that if they do vasodilate, because we've increased their volume, therefore increasing their pressure initially, if they dilate out, then they still should maintain a normotensive pressure. So you have to be careful about saying, oh yes, you can get it whenever you want, because sometimes it's not going to be just that easy. Thinking about, you know, the speed of, you know, onset and peak with your IV versus your IM medications. Just in general, you know, safety issues. If you've got somebody who's had an epidural or a spinal, you don't want them getting up by themselves. Now, women who have had epidurals will be able to move their legs. They can even hold them in a certain position. They may feel fine, but if they go to stand up and try and put pressure on them, they're going to break like a stick, okay? So women who have had either epidurals or spinals do not get up and ambulate on their own without assistance the first 2-3 times, okay? You got to stress the importance of that. As always, if you're giving medications, you determine what their pain level is. You should have already determined what their acceptable pain level is, so you have your point of reference. You administer your medication, and then you go back and you assess the effectiveness of that medication. Now, if she's laying there laughing and just joking with everybody and says she's hurting a 9 out of 10, then you have to document that she's hurting a 9 out of 10, and you treat that as per ordered in her chart. Whenever you go back, if she says she hasn't got any relief at all and she's texting on her phone, laughing at the TV or whatever, you have to document that. Now, I don't see that happening. However, that is a very real scenario that could happen. You have to take the patient at their word. Whatever they say is what you have to document. But then you always have to remember to go back and determine what effectiveness, good or bad, did the pain medicine have for that patient. All right, so now we're going to switch gears and we're going to start talking about the fetus, all right? And the rest of the slides will be associated with fetal monitoring. In 1970 is when they first really started using fetal monitoring to track the fetal status in utero during labor. The concept was that when a fetus is distressed, it's distressed because it's hypoxic. It's had some issues in labor and the birth process. So the anticipated net effect of using monitoring and being able to track what theoretically the fetus was experiencing was that there would be a decrease in your cases of cerebral palsy and birth injuries. However, what has happened over the course of the subsequent years is that the rate of CP has actually gone up slightly. This hasn't caused us to quit using fetal monitoring though, because if as much as anything, it seems to be a little bit of a comfort to providers to be able to say, here is what my baby seems to be doing. Here is what my baby is experiencing. Based on this strip, my baby is happy. The unfortunate reality is you can have a bad, nasty, crappy looking strip with a lot of recurrent late decels and minimal variability to splotchy absent variability. It can be a really bad looking strip and you can have a very good baby. Or you could have the most perfect strip in the world, textbook reassuring with accels, moderate variability, normal baseline, and you could have a compromised baby when it's born. So fetal monitoring isn't an absolute, but it's the next best thing we have to telemetry monitoring on our fetus in utero. So what the fetus does during labor really is directly related to how it's been prepared for labor and what's going on. Labor is a stressful period, okay? You have to think about how the baby's getting its oxygen. Remember, when the uterus is relaxed, it fills up with blood. There's about 400 mLs of blood in the uterus when it's relaxed. That blood has oxygen. It fills those intervillous spaces. The chorionic villi extract the oxygen from the blood, take it through the placenta, through the umbilical cord to our baby. So we get oxygen. Well, if there's anything that goes on during gestation or once we hit the stress of labor and the contractions, then that fetus's continuous oxygen supply gets interrupted. And how it gets interrupted is dependent on the frequency and the duration of the contractions. How it tolerates having its oxygen supply cut off is a direct relation to the amount of fetal reserves or stores that it has been able to accumulate during the gestation period. So things that can be associated with fetal oxygen supply decrease leading to fetal hypoxia. Well, if you have mom with either chronic or pregnancy-induced hypertension, she is going to have vasoconstriction. If she has vasoconstriction, she is not going to have adequate perfusion. If it is chronic hypertension and it has been there during the entire pregnancy, she is probably not going to have laid down a very good placenta. Think about nice, big, beefy, juicy placentas, a lot of blood circulating through them, a lot of gas exchange. That's a normotensive person. If you've got somebody who is chronic hypertensive, has poor perfusion, poor circulation, they're going to have a puny little crystal burger placenta. So it is not going to have a lot of availability for blood saturation and for oxygen transport. So hypertension, either chronic or towards the end with its vasoconstriction, can impede fetal oxygen supply. Conversely, hypotension can be just as bad as hypertension. Now, hypotension could be something as simple as she's laying on her back. Okay, so if she's laying on her back, we know the weight of the fetus is pushing against the aorta and the inferior vena cava. Therefore, it is diminishing circulation, and so she's not going to be perfusing her uterus very well. It can also be from hemorrhaging, from bleeding out, a side effect of the epidural medications that she has. So if she has hypotension, then her blood pressure drops. If her pressure drops, then her body says, well, I have to save the important things, so let me make sure I get oxygen to the important parts of my body, my head, my heart, and my adrenals. The womb, the uterus, is not considered an integral part of the woman's body. It can survive without that, so it doesn't worry about pushing blood there. So if the blood doesn't go to the uterus, it doesn't go to the placenta, and it doesn't go to the baby. A reduction of the oxygen content in maternal blood because of hemorrhage or anemia is obviously a critical thing, because if the oxygen itself isn't circulating in the maternal blood, there's not going to be adequate oxygen to circulate through the fetal system. If you have fetal circulation compromised with the umbilical cord, if there is a true knot in the cord, there is no position change, fluid bolus, oxygen, or anything that's going to alleviate that, because a knot is a knot. If the cord is wrapped around the baby's body or around the neck, every time you try and push the baby out, it in essence is squeezing around the baby, but it's also squeezing that cord. So if you're cutting off circulation through the cord, then that's the lifeline that you're cutting off oxygen to your baby. And then all of those things and the contractions, everything we've talked about, if you have a decrease in the blood flowing to the intervillous spaces, then that's where the gas exchange takes place. I get my oxygen and give off my CO2. So if you don't have blood in the intervillous spaces, you're not going to have good perfusion. So we determine the status of fetal well-being by looking at the relation to the contractions and the fetal response to the contractions. So we say we have either a reassuring pattern or a non-reassuring pattern. Reassuring patterns will have a normal baseline. Baseline is 110 to 160 beats a minute, moderate baseline variability, and no periodic changes. You do want to have accelerations. They're not a have to, but if you see them, we consider that reassuring. If you have accelerations in the fetal heartbeat, usually it's in response to a stimulation or to fetal movement, but if it can accelerate its heartbeat with some sort of stimuli, then that tells you acid base should be normal. The fetus cannot be hypoxic and in distress if it can accelerate and maintain its heart rate when it's stimulated. Decelerations we'll talk about a lot more in detail in a few slides, but not all decelerations are bad, okay? However, if you have recurrent late decels or recurrent variable decels, those are not considered reassuring. You also want to look at the uterine activity. The frequency and the duration of contractions are obviously very important. You got to see how fast they're coming and how long they're lasting. But another very important piece of uterine activity is the intensity of that contraction, and then what is the subsequent resting tone. So are the contractions strong? But even more than that, once the uterus is relaxed, does it come back to a completely soft tone? Because if it's soft, then you would imagine that it's completely relaxed so it can fill back up with blood. But if it doesn't come to that complete soft tone, then you are going to have a decreased amount of blood that can flow back into it once it's relaxed. With monitoring, you're wanting to do everything you can to identify any potential fetal compromise and be able to intervene before anything untoward happens. Okay, if you see a non-reassuring pattern, you do have to wonder, do I have fetal distress going on? Am I deficient in oxygen, hypoxic, and why? So what do I need to do about it? Hypoxemia can deteriorate to severe fetal hypoxia, and you don't really know at what rate it's going to do that. Okay, if it is something that seems to be present just in labor, maybe just when she's pushing and she starts having recurrent late decels, a very acute onset of something that's short-lived, the fetus can generally turn around from that pretty quickly once it's out and starts breathing on its own. But if you've had a fetus that's been hypoxic in utero for a while, now we're starting to get more into the metabolic aspect of it, because you've had anaerobic activity going on in utero, and that starts getting to the cellular level, and the fetus, i.e. transition to the neonate at birth, is not going to be able to turn things around just by taking a couple deep breaths. Now, we said earlier, a reassuring fetal heart rate is normal baseline, moderate variability, and the presence of accelerations. So, what's non-reassuring? Well, if you have tachycardia or bradycardia, something's not right. Okay, tachycardia is typically going to be a stress response. Bradycardia is a last response, and it's like, my baby is now sick. Absent or minimal variability. Now, if your baby's asleep, it may have minimal variability, okay, but you don't know that. So that's why you're not reassured by seeing that, okay? Absent variability is, there's something going on. Variability in your baseline is an indicator that your fetus is oxygenated at that point in time. So if you have absent variability, that leads you to believe my fetus is not oxygenated at that point in time. Minimal variability says, okay, there's some oxygen there, I just need to know what's going on. Absent variability could indicate no oxygen to the fetus. If you see variable or late decelerations, that is something interrupting oxygen getting to the baby. Okay, remember, the variable is your cord compression. So if I'm seeing variables, especially recurrent variables, my cord is getting kinked, so I am not having circulation to my baby. If I'm seeing late decelerations, that's coming after my uterus has contracted and now it has relaxed. I'm getting blood with oxygen flowing back into my uterus, so I should be getting that to my baby. But there's something happening, because after that contraction, my baby is going down in its heartbeat and it's saying something's not right. And then anytime you have a prolonged decel, you have to worry about it. Remember, prolonged decelerations are when your baby's heart rate drops for more than 2 minutes at a time, but it only stays down less than 10 minutes. If it stays down for more than 10 minutes, it is considered a baseline change. To do fetal monitoring, you have two venues. You have an intermittent and electronic fetal monitoring. The electronic fetal monitoring, because it is continuous, is viewed as, especially in labor, as being the better option. But you can do intermittent auscultation in early labor. You can do that whenever maybe they're on antepartum and you just need intermittent surveillance. You don't need that continued surveillance. Intermittent auscultation is done with either a fetoscope, and I don't know if y'all remember that from pictures earlier in the semester, but it's like a stethoscope, and the bell of the stethoscope is put against the abdomen, and you can actually hear the baby's heartbeat through that. With a fetoscope, you actually hear beat to beat in the heartbeat. So if there's an abnormality, if you think you hear an arrhythmia, you can ascertain that with a fetoscope. When you're listening with a Doppler ultrasound device, one of the little wands that you put on there, and it's whoosh, 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 like that, you can't really say that you're hearing an arrhythmia, because what you're hearing is sound waves reflected. You're not actually hearing beat to beat. With intermittent auscultation, there does take some skill and technique to be able to do that. It's not as easy as just putting the wand on the belly and automatically you get a fetal heartbeat, especially if you've got a larger abdomen mom and maybe you've got a layer of adipose to get through. It's not the easiest thing to be able to do. Now, your continuous monitoring, your EFM, you have two routes with that. You have an external or an internal. External is with the ultrasound, and that's the little round device that's put on the outside of the abdomen. The same way the Doppler picks up sound waves, the ultrasound picks up sound waves. But if you have a mom, again, with a larger belly, or maybe you've got a very active infant or fetus that just does not want to be still so that you can trace it, you can use invasive monitoring with a fetal scalp or fetal spiral electrode. It's just a little like corkscrew. It's not as big as a corkscrew, but it looks like a little pigtail coil that just screws right under the skin of the scalp. And that is actually as effective as fetal EKG, because it is getting direct cardiac activity. So those are your two, internal or external, when you're doing your electronic fetal monitoring. All right, so here you just see depictions of tracings from external to internal monitoring. So we're going to look at side A first. This is our external monitoring. When you're looking at your paper, the top part is your fetal heart rate, okay? It says ultrasound because the ultrasound is what's picking up the baby's heartbeat. The little squares going across or going up are 10, okay? So across, it's in seconds. So each little square is 10 seconds. From solid line to solid line is 60 seconds or 1 minute. When you're going up the grid, you're talking in beats per minute. So you have 30 beats, 60 beats, 90 beats, 120, 150, 180, and so forth. So you look at the baseline. To be able to determine baseline, you have to have 2 minutes of baseline that is not in an accel and it's not in a decel. It is the baseline. They don't have to be 2 continuous minutes. It could be 30 seconds and then an accel followed by 45 seconds and then an accel followed by a minute or something. But you have to have 2 total minutes of time to be able to determine your baseline. When you're doing continuous monitoring, you always put it in a solid number in increments of 5. So it's 140, 145, 150, 155. You will round to the fives. When you're looking at the bottom, you see uterine activity. From the beginning of one contraction to the beginning of the next contraction is your frequency. From the beginning of the contraction to the end of the contraction is the duration of the contraction. Between contractions, that resting tone baseline, you want it to be less than 20. Okay, if it's higher than 20, then that resting tone does not come back to a fully relaxed state. When you have a patient that you are monitoring intensity and resting tone with something called the tocotransducer, it's a pressure monitor, you can only say the resting tone is soft. The intensity of the contraction palpates as mild, moderate, or strong. You cannot give millimeters of mercury when you are using a tocotransducer and talking about pressure. Now flip over to side B, and we're going to go down to the uterine activity first. You see where it says intrauterine pressure catheter? If you have a pressure catheter inserted into the uterus, you can then say millimeters of mercury when you're talking about resting tone or intensity. Duration and frequency is still measured the same way, either beginning of contraction to beginning of contraction or beginning of contraction to the end of the contraction for the duration. But when you're talking about how intense that contraction is, you can actually now look on your tracing paper, and whatever the millimeters of mercury that the acme of that contraction is, that's what you can say the contraction pressure is. Whatever the resting tone is, you can say it is 20 millimeters of mercury or 15 millimeters of mercury. When you're going up and looking at the fetal heart rate tracing with the spiral electrode, you're still going to be gleaning information the same way. You're still looking at your baseline, you're still looking for your increases or decreases, you're still looking for your variability. Okay, so to kind of recap from what I talked about in the previous slide, baseline fetal heart rate, okay? Baseline is averaged during a 10-minute segment. You cannot include increases or decreases. So accels or decels, you don't count that part in determining your baseline. If you have marked variability, you can't determine baseline because you can't see it. And we've got examples of marked variability a little bit later on so you can see what I'm talking about. It's only the baseline, and you have to have at least 2 minutes of baseline to be able to determine a baseline rate. Normal baseline is 110 to 160 beats a minute. So once you've got your baseline determined, then you want to look at the variability. Variability is the squiggliness in the baseline. Okay, it is the amplitude of up and down fluctuations in the baseline. And as I said earlier, variability tells us about our fetus oxygenation at that point in time. In order for variability in your baseline to happen, you have to have your autonomic nervous system, your sympathetic and your parasympathetic, working together to increase and decrease your baseline, your heart rate. So the variability, when you see it, that is indicative of an intact neurosystem, first thing. And then variability also tells you that I have oxygen at that point in time. Now tachycardia, just like you have tachycardia for us, for the fetus, it is when the baseline is 160 beats a minute for 10 minutes or longer. Bradycardia is less than 110 beats a minute. Okay? I know it's confusing, that 10 minutes. The reason that 10 minutes are in there is because if you have a prolonged acceleration or deceleration, then it could make the heart rate go up to a tachycardic stage or drop down to a bradycardic stage. But if it comes back to the previous baseline in less than 10 minutes, it is not considered bradycardia or tachycardia. It's an acceleration or a deceleration. If it stays up above 160 for 10 minutes, then that's tachycardia. If it stays below 110 for 10 minutes, that's bradycardia. So here you can see a depiction of the different variability ranges, so to speak. If you look at A, that is absent variability. Doesn't that almost look like asystole, just flat line? That's kind of what the baby's trying to tell you, okay? Absent variability, I'm not oxygenated at this point in time, I need you to do something. If you go over to B, then you have minimal variability. Minimal variability is less than or equal to 5 beats per minute of amplitude. It's kind of like peach fuzz in your baseline. It's just there. You can see it, but it's just there. So it only has to go up and down half a block, because remember the blocks when you're moving up are 10 beats a minute, so it only has to have a fluctuation that is about half of that block. Now C is moderate variability, 6 to 25 beats a minute. It is what we love to see, okay, because if our baby has moderate variability, we presume that it's pretty adequately oxygenated at that point in time. So moderate variability is going to be much easier to see. Now, because it has such a wide range in the amplitude, you may see bigger little spikes and smaller ones, but it's going to fall between that 6 to 25 beats per minute variability. When you look at D, doesn't that almost look a little bit like VTAC or something? If you're looking at an adult with that up and down sharp and everything, that's your stress indicator. Your fetus is saying something is wrong and you better do it something quick, okay? So if you have more than 25 beats per minute amplitude in your baseline beat to beat, then that's marked variability. Remember I said you can't get a baseline in marked variability, because if you look at that, is there anywhere that you can see a solid straight 2-minute segment where you can determine what the baseline is? And you should be sitting there shaking your head no, because you can't. So when you see marked variability, generally indicates stress. You need to determine what is causing the stress and you need to intervene so we can get that variability back down to moderate and we can determine what our fetal baseline is. If you see this waveform, your sphincters tighten up, your gut clenches, you feel nauseous, and you're like, oh fudge, I got to do something quick, okay? Sinusoidal fetal heart rate patterns are category 3. This is imminent delivery, big potential mess is about to happen. We have got to get the baby out. The sinusoidal pattern is attributed to severe fetal anemia. The most common cause is going to be hemorrhage. When you have a placental abruption or uterine rupture, something that is taking the blood away from the fetus. And so if I'm taking the blood away, I'm taking the oxygen away. And the fetus becomes anemic. It has no oxygen, it has no hemoglobin, it has no nothing. You will get this waveform. This is almost like VFib to me, okay? VTAC was that stressor that, hey, you need to do something, get me out of this quick or it's going to be bad. This is kind of like VFib, that, okay, it's already bad, you either get me out or it's not going to be a good outcome. In this slide, you can see an example of fetal tachycardia. If you count it up, then the fetal heart rate, you can see at 150, 160, it's riding right on 170. As far as variability goes, I would have to say it's minimal. It doesn't look completely absent, but it's not more than 1 to 2. But remember, it only takes that little bit of peach fuzz to have variability in the baseline. But if you have fetal tachycardia going on, there's generally some stress. The tachycardia is the fetus's way of alerting you, hey, I need some kind of intervention done. Now, just looking at the uterine activity below, you have a resting tone that looks like it's down less than 20. You're not having a tachysystole, your contractions, I don't know if it's an IUPC or not, but the intensity doesn't look overwhelming. So if I'm seeing tachycardia, I'm wondering, Do I have maternal fever? Do I have maternal pain? Do I have some kind of maternal stressor that means mom is shunting blood away from the uterus, so I'm hypoxic because of mom shunting, so I'm getting tachycardic to kind of get you to pay attention to what's going on. Now, fetal bradycardia, remember, is a sustained fetal heart rate for more than 10 minutes of less than 110. So this fetal heart rate is 30, 60, 90, 100. Again, variability, I mean, you could probably argue minimal at best. It doesn't look completely smooth to say it's absent. If I had absent variability with bradycardia, that's imminent delivery, okay? And I look down at the uterine activity, and there's really not a whole lot of activity going on, so I'm not exactly sure. Do I have a sick fetus? Is there something neurologic with the fetus? What's going on here? All right, so we talked about fetal baseline. Now we're going to talk about changes in the baseline and what that does to the fetal heart rate pattern. You have periodic and episodic changes that can occur. Your periodic changes occur with your uterine contractions. It's like with uterine contractions, you expect them to occur at specific intervals. When a woman has a period, you expect a period to occur every 28 days. So you start prepping yourself when you get closer because you know at day 28 something's going to happen. If you're having periodic changes, then when you have contractions, you start prepping yourself that something is going to happen with the fetal tracing. Episodic changes are not related to uterine contractions or activity at all. It's just a random event that can occur. It may happen around a contraction, but it is not related to the contraction. Okay? So you have periodic changes associated with your contractions, episodic changes which are not associated with the contraction. So what kind of changes do you see? Well, the heart rate's either going to go up or it's going to go down. Okay? If it goes up, we call that an acceleration. There are two sets of criteria that you have to remember, and that's associated with fetal age. If your fetus is less than 32 weeks gestation, then to be an acceleration, the fetal heart rate has to increase 10 beats a minute, and it has to stay up for at least 10 seconds. So if I have a 30-week pregnancy and I have a fetal heart rate baseline that is 145, sorry, and it goes up to 155 and it stays at 155 for at least 10 seconds and then comes back down to 145, that's an acceleration. If it's at 145 and it goes up to 150 for 10 seconds and then comes back down, that is not by definition an acceleration because it didn't go up 10 beats. If your fetus is after 32 weeks, then the criteria change to 15 beats a minute for 15 seconds. So if my fetal heart rate is 140, then it has to go up to at least 155 and it has to stay at 155 for at least 15 minutes before coming back down to baseline. If it's at 140 and goes to 155 for 10 seconds and then comes back down to baseline, that is not an acceleration because it did not hold that increase for 15 seconds. So before 32 weeks, 10 by 10. After 32 weeks, 15 by 15. Accelerations are indicative of acid base being normal at the time that you see the acceleration. So oxygenation is theoretically good, intact. Your fetus cannot be hypoxic because acid base is normal. Decelerations. You have 4 types of decelerations that you have to remember. Early decels, variable decels, late decels, and prolonged decels. Okay? Your early deceleration is actually a good thing. It's the fetal head has come down, engaged. When you have a contraction, the contraction actually squeezes on the fetal head. That squeezing results in increased intracranial or cerebral pressure in your fetus. Because you have that increase in the cerebral pressure, you have a physiologic response triggered by baroreceptors to drop the heart rate. Increase pressure, decrease heart rate. Okay, so as that contraction is squeezing against the head, then the fetal heart rate is concomitantly dropping down. So once that maximum squeeze happens, which is the peak of the contraction, that mirrors the point of the lowest drop in the fetal heart rate. Once that contraction starts releasing, then the cerebral pressure in your fetus starts going back down, and if the pressure starts going back down, my heart rate starts going back up. So early decels are actually just cues to tell you, hey, my fetus's head is dropping down into the birth canal. It's not a bad thing. Variable decelerations are caused by cord compression, whether the cord is prolapsed, whether it is wrapped around the body, whether the infant has it in his hand and is squeezing on it, whether it's trapped between the fetus's body and the uterus during contractions. Anything that compresses on the cord is going to result in a variable deceleration. Your late decelerations are straight up associated with uteroplacental perfusion. If I am not adequately perfusing from my uterus to my placenta to my fetus, I'm going to have late decels. And again, your prolonged decelerations, when the fetal heart rate drops below baseline for more than 2 minutes but less than 10. So here you see accelerations, and I actually went in and drew circles around them so that you could see. But where it starts going up in the first one, you can see that it's probably halfway in a block. So that is 10 to 20 seconds that the heart rate goes up before it comes back down. And then if you're counting upward, it goes up 10 and then probably halfway. So that looks like a 15 by 15, okay? When you go over to the second one, it looks like it's up and starts up, and I don't know that it is staying up for the 15. It starts up, but I don't know if it stays up. That is more of like a 10 by 15. So I would want to know what the gestational age on this fetus was to be able to determine, is this an accel that meets less than 32 weeks criteria or greater than 32 weeks. That's going to tell me, do I see one acceleration in this tracing or do I see two? All right, so here we see early decels. Remember that your early deceleration is directly related to head compression. The fetal head is coming down, the uterus is compressing against it, it increases cerebral pressure, which triggers a vagal response, which causes the baby's heart rate to drop. Okay, so if you look at the arrows, you can see the decrease in the fetal heart rate is directly associated to the increase of the uterine contraction. The nadir, or the lowest point of the fetal heart rate descent, is directly on top of the apex of the uterine contraction. So they actually mirror each other. And if you look throughout the tracing, you can see that. It is a nice, even pattern. It takes more than 30 seconds from the point it starts dropping down until it gets to its lowest point, okay? So if it is a gradual onset, the nadir of the decel mirrors the apex of the contraction. That is considered an early decel. Early decels are not bad. They just tell us the fetal head is coming down, engaged, and it is getting squeezed. The baby, as I tell moms, the baby's head has to come down to come out. This is just an indicator to us that labor is progressing. Here we see a late decel. Now remember, late decelerations are directly related to poor uteroplacental perfusion. Okay? When the uterus is contracted, all the blood goes out of it. Fetal hypoxia occurs because there's no perfusion, no circulation. But once that contraction is over and the uterus relaxes, blood surges into the uterus, into those intervillous spaces. The chorionic villi should be able to pick the oxygen up, carry it from the placenta through the umbilical cord to the fetus. So you should have a good fetal baseline. Well, after the contraction, if the placenta and the uterus aren't working together and adequately perfusing, you don't have that return of oxygen to the fetus. So the fetus has been holding its breath during the entire contraction. After the contraction, it still has to hold its breath, and it may not have enough reserve to be able to maintain a higher heart rate, so the heart rate drops after the contraction. This could be a sign that your fetus is not going to be able to maintain adequate oxygenation for the remainder of the labor if the late decelerations continue. So when you look at the picture here, you can see where they have their line with the arrows. The fetal heart rate starts dropping after the contraction, and then the lowest point of the fetal heart rate, the nadir, occurs after the peak of the contraction. Okay, so in all three of these, it looks like it's almost a little bit later and a little bit later in the contraction. For late decelerations, it is a gradual decrease in the fetal heart rate from baseline to nadir. It takes more than 30 seconds to get to the lowest point. The lowest point occurs after the peak of the contraction. It can be just after the peak of the contraction to almost after the contraction has ended. But for a late decel, it is gradual, takes longer than 30 seconds to go from baseline to the lowest point, and the lowest point occurs after the peak of the contraction. Very important to remember that. Conversely, in timing, your variable decelerations are going to be an abrupt decrease from baseline to nadir, or the lowest point. Those variables almost look like V's, right? Sharp down, sharp up. So just somehow or another, keep it in your mind. It's very, very important to keep it in your mind. Variable decelerations are less than 30 seconds from baseline to nadir. Okay? It's a sharp down. How long it stays down really doesn't determine if it's a variable or not. It's how fast does it go from baseline to nadir. It may or may not be associated with a contraction, because the cause of a variable deceleration is cord circulation, cord compression. So you may not even be having good, strong contractions yet, but depending on what position your mother's in and where the fetus is, the fetus could roll over and it could lay on its cord and it could compress the cord, and there's nothing about a contraction that's associated with that. So variable decelerations directly related to cord compression. You look at how fast the heart rate goes from baseline to nadir, and it will be less than 30 seconds. So variable decelerations, less than 30 seconds. Early or late decelerations will take longer than 30 seconds. Please, please commit those two things to memory. And your prolonged decel is pretty much what it says. It's a deceleration in the fetal heart rate for a long period of time. So it's going to go down 15 beats a minute, and it's going to stay down for more than 2 minutes at a time, but it will come back to its predetermined baseline in less than 10 minutes. If it stays down for more than 10 minutes, then it becomes probably a bradycardia, okay, or at the very least a baseline change. So say if your fetal baseline was 150 and then you had a deceleration that looked like it was a prolonged deceleration and the fetal heart rate was 130 in this deceleration, if it went back up to 150 in less than 10 minutes, then it was a decel. But if it stayed down at 130 for more than 10 minutes, then that becomes a baseline change to 130. So as nurses, what is your job in taking care of these two patients that you have in the bed? And first and foremost is to be able to recognize what's going on, to accurately identify, am I seeing earlys, lates, variables, accels, or what? Understand what's causing these changes in your fetal heart rate pattern, and then know what interventions are necessary, know what you would expect those interventions to do, and then if it works, great. If it doesn't, you need to know why so that you can go to step 2. Okay? So you need to be able to recognize the pattern. Look at the evolution. How is it changing? What all is associated? Is mom stressed? Is she in pain? Is she sick and fevered? Am I getting close to delivery? I may be seeing a lot of variable decelerations simply because my fetus is now in the birth canal and that cord's down there with it, and every time she has contraction or pushes or whatever, I'm kinking on that cord. So what's going on? You need to be able to relay this information to the delivery provider so that they can anticipate when their presence is needed, and what they need to do and how they need to be prepared. And if you need to initiate the chain of command because maybe somebody isn't intervening for late decels, they're telling you to turn the pit up instead of turn the pit down or off or anything like that, you need to understand what the chain of command in your area is, and you need to be willing to activate and go up that chain of command to advocate for your patient. Now, if you have a non-reassuring pattern, bradycardia, tachycardia, recurrent lates or variables, anything like that, you need to know what to do, where to start. And the first thing is look at your mom, because that's the patient you can touch, you can see, you can feel, and you can ask questions of. How is she doing? Is she feeling pain anywhere? Does she feel her contractions? Does she feel the need to push? What's changed? You need to do your maternal assessment. Interventions are going to be almost consistently the same across board for anything that happens. The first thing you're going to do is change her position. That's something that you can do. It's at the bedside, it's immediate, and you can be doing that while you press the button and you're calling for help to come in because you're going to do something else. So changing position is an immediate thing that you always do first. Next thing is the fluid bolus, okay? You got to think about hypoxia is what we're worried about, okay? So increasing fluids isn't going to necessarily increase oxygen per se, but if I'm increasing the circulating volume, I'm increasing the pressure, which means I can enhance circulating volume and theoretically enhance perfusion because I'm helping that pressure stay up so it can circulate. Oxygen is a drug. We sometimes forget that it's a drug, but it is a drug. But you always consider oxygen, okay? If hypoxia is what we're worried about, if I have less oxygen circulating, then if I can give mom more oxygen, increase her oxygen carrying that's in her circulating volume, theoretically I'll be able to give more of that to the fetus. We don't leave oxygen on indefinitely. We only leave it on for a short amount of time until we see a fetal response or we have to go to plan B. Another medication that's not on here to consider, and this is with a physician's order, is breathine, terbutaline. If you're having uterine contraction pattern that is tachysystole, you're having too many contractions so that the uterus doesn't have time to relax and fill up with blood, then you can give it terbutaline, and that can help relax the uterus a little bit. So your medicines are always important. And then management of your oxytocin, your pitocin. If you have to give a mom oxygen, you should turn the pitocin off because they are counterproductive to each other. The fetus isn't getting oxygen because the pitocin is causing the uterine activity to be too fast, or the uterus is not coming to a soft resting tone, so we can't get blood into the uterus. So why do I want to give the mom oxygen to increase the oxygen amount in her blood if I'm not getting the blood to the uterus? So if you turn the oxygen on, you turn the pit off. When you're giving O2 in labor and delivery, 10 liters non-rebreather face mask. It is not nasal cannula. It's not any other face mask. It is 10 liters in a non-rebreather face mask. Now, there are some other methods that can be utilized to just determine what our fetal status is. Something that is not done in the States anymore, but it was done in the past, we just don't do it anymore, is fetal scalp blood sampling, looking for pH in the blood. But it was actually a very messy process, and it was a laborious, tedious kind of process that typically gave you false results, because by the time you could actually get the blood sample tested and analyzed, it was too late. If y'all want to know about it, ask me about it in class. I'll go into the detail of it, but we don't do it very much in the States anymore. What we do is fetal scalp stimulation and vibroacoustic stim. If you're doing a vag exam on the mom and you stroke your finger across the fetal scalp, that should elicit an acceleration in the fetal heart rate. That's a stimulus to your fetus. Now, not getting it isn't an absolute bad thing, but you're going to investigate why you didn't get a response. But if you want to see, okay, is my baby maybe just sleeping or something like that, then I can do a scalp stim. Providers should never do a fetal scalp stim to get a baby out of a deceleration. That's actually a no-no. I've seen them do it before, but it's really a no-no. The vibroacoustic stim is kind of like that laryngeal box amplifier thing for people who maybe have had trachs and they can't, their voice box is gone, so they can't really talk, and then they put the little device up on their neck, and you can actually hear it through that. It's like a bzz, bzz kind of thing. If you stick that to the abdomen, very brief, 1 second little bzz, the sound should stimulate your fetus. So those are two ways to try and elicit an acceleration from stimulation. Fetal pulse oximetry isn't done routinely, but it does give you a good depiction of what your fetal SaO2 is in utero. Umbilical cord acid-base determination. That's a long way of saying cord gases. This is gaining popularity by providers, especially if there has been any type of challenge or non-reassuring period in the labor and birth processes. The same way that we can do arterial blood gases on people to see if they have if they're acidotic, metabolic, or respiratory acidosis, you can do a cord gas to be able to figure the same thing. Now you have to remember, whenever you're looking at the cord gases, you're wanting to get a reflection of what's been going on with the fetus, okay? For oxygenated blood, it is in the umbilical vein that we have oxygen going to the fetus, and the umbilical arteries, we have CO2 coming away from the fetus. So when you're looking at pH, if you're looking at the umbilical vein, you want a pH to be between 7.3 and 7.4. Anything lower than that could be indicative of an acidosis. If it's the artery, it's 7.2 to 7.3. When I teach fetal monitoring to the nurses at the hospital, we look for cord gas values. Anything greater than 7.1 is not acidotic. It's a normoxic fetus. There was no compromise. Anything less than 7.1, then I have to look and see what my O2 and my CO2 levels are to determine was it a respiratory, a metabolic, or a mixed. We won't need to get into all of the details of that. If you were working labor and delivery, you would. What you need to know is that the cord gas looks at the acid-base determinant. It checks to see what level of any acidosis could be occurring. If you see a respiratory acidosis on your cord gas result, that's generally associated with just a short-term acute hypoxic insult, and the fetus should be able to turn it around pretty quickly after delivery once it starts breathing and is able to blow off that CO2. If you see a high CO2 value and a low PO2 value, generally less than 20, then you're going to have a mixed acidosis, and you're starting to get into the metabolic acidosis, which is generally consistent with more of a long-term insult versus just the acute insult. Another thing that's not on here, because we'll talk about it when we get into the delivery of the neonate, is your APGAR assessment. We do a 1 minute and a 5 minute APGAR assessment. We want the score to be greater than 7. If the score is less than 7, there's something going on. Now there's different components of it I won't go into, just know 7 is kind of our number. That 1 minute APGAR reflects how the neonate was while still in utero. So if you have an APGAR score of 7 or more at 1 minute, generally you can presume that the fetus was not distressed, was not hypoxic in utero. If that APGAR score is 6 or less, then there is something going on. It was stunned. It had some level of hypoxia occurring at some point. Now, amnioinfusion is an intervention where you actually infuse fluid up into the uterus if you're seeing a lot of variable decelerations. You got to remember the amniotic fluid is kind of the cushion. It's where the cord floats around. It kind of keeps everything off of each other. So if you've had maybe a prolonged rupture, baby's not down far yet, recurrent variables, then infusing fluid up into the uterus can kind of help mimic what that amniotic fluid would do. Again, the tocolytic therapy, talking about our terbutaline to relax the uterine muscle, to be able to let it quit contracting so much and fill up with blood a little bit. Very important teaching, maternal positioning. Remember, we want to change positions frequently, but when we're seeing anything concerning placental perfusion, we want mom to be in a side lying position. Left side lying is kind of like our go-to. Discourage Valsalva closed glottis pushing. So instead of telling her take a deep breath in, hold it, and push, and she's ooh, you want to make sure that she uses that open glottis pushing and lets a little bit of air out. Helps keep her intracranial pressure down and helps promote her cardiac output. When you are documenting your care, you're going to be doing continuous monitoring, but assessing what you see on the strip and documenting is pretty much going to be relevant to the stage of labor that she is. Is she high risk or low risk? And you definitely, anytime you do an intervention, you want to go in and document that, okay? So, early on in labor, you may be documenting every 30 minutes what your fetal patterns are. Once we start getting into transition and we get into stage 2, you're going to be documenting every 15 to 30 to every 5 to 15 minutes, depending on the patient and what's going on. Any intervention, changing position, giving a fluid bolus, calling the provider, giving medication, anything that you do, you need to document. Whether it is, if you have electronic health records, typing it in and stamping it on the strip, or if you're still doing pen and paper for some reason, writing down, you need to make sure that you're documenting. When you're documenting, it's a very systematic approach. Baseline, variability, increases, decreases, uterine activity, frequency, duration, intensity, and resting tone. All of those pieces should be in your documentation. If you are documenting intensity and you do not have an internal pressure catheter, then you're documenting the contraction intensity as mild, moderate, or strong. And then the resting tone should be a soft resting tone. It's always going to be palpation unless you've got a IUPC, at which point you can actually say millimeters of mercury. And as with any plan, you have to intervene, you have to determine your patient's response to your interventions, and then you need to evaluate what you've done, modify it based on patient's response or where you are in that plan of care. All right, so that's chapters 10 and 11, labor and then fetal monitoring in labor. If you have any questions about anything that I talked about in this lecture, please write it down and bring it to class and we'll go over it. It would probably be a good idea for you to review the slides on fetal monitoring that were done in those first 2 days of the semester in the clinical group. For those of y'all who may not be taking clinical this semester, if you will let me know if you are interested in getting those slides. I will make sure that they get sent to you so that you have a copy of them. When trying to remember what causes what, remember the acronym VIL CHOP. If you remember that and commit it to memory, you will always be able to determine what you're seeing on your strip. So that might come back to visit y'all at some point, so it's probably worth remembering. So y'all have a good evening, and we will talk about this the next time we see you in class. Bye.